All right, just gonna let everyone hop in while I go over some housekeeping items. All right, well, welcome everybody to the 2025 Digital Health Summit brought to you by the California Telehealth Resource Center. We're glad you could join us for today's session, AI versus MD, Can ChatGPT Outsmart Diabetes, Heart Disease, and America's Obesity Crisis? As you know, the theme of this year's event is Technology Supercycle Meets Healthcare, leveraging digital health services to combat the chronic disease crisis and other challenges. Before we begin, I would like to go over a few tips to help you navigate the conference. First, this session is purely for informational purposes. CTRC has no relevant financial interest or arrangement with any organizations related to commercial products or services discussed during the summit. Next slide. Just a note that you do have to register to join each session. So if you haven't already, we're going to drop a link in the chat and we hope to see you at the other sessions later on today. Next slide. You can use the Zoom functions to ask questions, post comments, and connect with fellow attendees. And we encourage you to use the chat feature to interact during the session. The session is being recorded and will be posted to the CTRC YouTube channel by the end of the month. If you encounter any technical issues, go ahead and reach out to a member of the CTRC team on the Zoom platform or contact us at caltrc@ochin.org. We'd also like to thank our funders, the U.S. Department of Health and Human Services and the California State Office of Rural Health for supporting the program and this digital conference. We would also like to acknowledge the contributions of our co-sponsors, the California State Rural Health Association and the Insure the Uninsured Project. With that, I am going to go ahead and pass it over to Sylvia, our moderator for today. Sylvia? Oh, you are muted.
Thank you all. I'm really excited to have you all here today. We have an exciting panel where we dive into potentially some high impact questions, really at the cusp of where we are venturing in the next chapter in healthcare and in clinical care. And essentially, we're going to address issues related can generative AI platforms, not really limited to ChatGPT, which is only one type of platform, but really outperform the trained human mind with regard to clinical decision making. I'm Sylvia Trujillo. I'm the executive director of the California Telehealth Resource Center. I'm going to moderate this really awesome panel. We are going to hold some time at the end of the discussion we're going to have for question and answer, and really encourage you to use the chat function to keep the conversation going. And with that, I am going to introduce a group of individuals that has been incredibly exciting and fun to work with in preparation of this panel. First up is Dr. Ethan Go, who's the executive director of Stanford's Arise Network. In addition to having dual degrees for MD and an MS, he is helping to lead the charge on rigorous AI evaluation through multi-site studies of large language model applications. That was a mouthful. In healthcare, in order to build the evidence base in what is clearly one of the most rapidly evolving and changing areas of healthcare today. Next, we have his compatriot and colleague, Dr. Adam Rodman, a practicing internist and award-winning medical educator at Beth Israel Deaconess Medical Center and Harvard Medical School. He's not only a practicing physician and an associate editor at the New England Journal of Medicine, because of course, why limit yourself to all of that? But he is also a storyteller and a podcast host, and he is really working to help the world understand the complexity and humanity behind clinical decision making through his work on the American College of Physicians Bedside Rounds podcast. And rounding out this really exceptional panel is David Vidal, a practicing lawyer. He is the chair of AI enablement at the storied Mayo Clinic, and his focus is on digital health. He is a pioneer, really, in both the medical and legal arena, where he previously served as a general counsel for a company that was the first to secure FDA de novo authorization for the first autonomous AI diagnostic system ever approved. He now leads the efforts at Mayo, supporting and collaborating with innovators in the large and sprawling Mayo system. And he works with these innovators in AI and digital health to navigate really complex FDA regulatory requirements and state requirements. And he's focused on building systems and infrastructure that enable safe and effective and ethical AI deployment at scale. So get ready for what will be a really thought-provoking conversation that likely will challenge some of your assumptions. So with that, I'd like to hand it over to Ethan first, and then Adam, and then David. They're going to provide a very brief overview of their work, and then we'll dive into a fireside chat.
Yeah, great. Thanks for the introduction, Sylvia. As Sylvia mentioned, I work very closely with Adam, Arise Network, doing a lot of studies around thinking, hey, what sort of capabilities do some of these large language AI models have? Where could they augment versus potentially, function semi-autonomously in a lot of these sort of medical applications? So I think what was really interesting in some of our more recent studies was that we found that AI alone actually did better than, in many instances, AI plus doctors using these tools. And I think a lot of our follow-up directions, which are super fascinating, right, is kind of like, hey, that shouldn't be the case if AI and doctor is not doing as well as AI alone. So how do we think about how do we measure and track the progress of doctors using AI-like tools? So really excited for this discussion, and I'll hand it over to Adam next to introduce himself.
Hi, everybody. I'm Adam. Thank you, Dr. Go. I mean, it's tough because like 50% of my work is with you, which means that there's a lot of overlap. But I think Ethan being very humble, what we really study, right? If you look at this new field, this kind of strange new field that we haven't had to grapple with for a while, is human-computer interaction with these kind of cognitive agents. And HCI is not a new field. In fact, many other fields, such as aviation, industrial safety, have dealt with this for a very long time. In medicine, we've been very comfortable to not worry about this. I actually think we should have been worrying about it a long time ago. And so I'm a historian, so if you go back to the 70s, there were really smart people who were talking about the effects that, for example, naive Bayesian algorithms had on doctors, and they were studying it. But really, for the last 30 years, there's been virtually no discussion about what computer algorithms actually do to human outputs. And that's unfortunate because now we're in a world where first we have superhuman, at least in certain domains, computer algorithms, these new reasoning models. I was talking about with Ethan and the panel before this, but we just had a preprint out 2 days ago from our emergency room showing real clinical data that LLMs, a very primitive reasoning model, so O1, is able to outperform humans in just reading the chart and give a second opinion. So these reasoning models are really able to outperform us in at least scoped domains. And one of the big questions that we're talking about today of what this means for healthcare actually has less to do with the technology, which continues to improve, and more to do with the humans. Meaning, how do we present that data to doctors? How do we create a regulatory space where it's safe to do that? How do we think about showing that these things are safe in every single situation? And this is a problem that we have not really had to deal with in medicine before, and in many ways has more to do with how we think about regulating human clinicians than how we think about regulating computers. So we're in a strange new world. I'm really excited to be on this panel, and I'm going to toss it over to David.
Great, that perfect tie into regulation. As Adam acknowledged, this is not new to safety critical industries, right? The aeronautics, driver, and medicine. We have structures and quality systems in place to know how to deal with new technology, even novel technology like AI. And so what I wanted to spend just a couple minutes on, I think it would be good for grounding, is what are we already currently doing? What is the FDA, what are regulators currently doing with respect to how they're governing and monitoring the risks and approving AI systems? There's over 1,000 AI systems that have been cleared by the FDA. Right, and maybe that's kind of unknown, but there's a legitimate structure here. Mostly, though, for those systems, they're locked machine learning, convolutional neural network systems, not generative AI. So what I'm going to try to do in 6 steps is describe to you what would be expected of somebody who's got a research AI algorithm. They like it. They maybe published on it. They want to deploy it into practice. What 6 things would they need to do in order to appease the FDA, get FDA approval, and move that from a research state into a practice state? It's hard to do. There's a lot of controls that are necessary to make it production worthy, but I'm going to try to describe it in 6 steps. It's more what the FDA is looking at right now, which is for locked algorithms, meaning they're not continuously adapting. But then I want to just spend the last maybe minute and describe, okay, well, now what are we going to do with generative AI? So 6 steps. Number 1 is once you have that system that you've built and you want to deploy it into clinical practice, you have to really hone in what is the very specific intended use that it's going to be. And you could have the exact same algorithms that it's intended for a general population versus maybe a pediatric population. That's a very different risk profile. So narrowing in on that intended use is really important. And part of that step 2 is actually writing down the requirements, product requirements, user needs, software requirements. The FDA is going to look for that to be actually written down to scope what you're intending to build. 2 of 6, and the most important in my opinion, risk management. The FDA expects formal, documented, written risk management processes. And that's literally a line by line. Here are the risks, the scenarios and harms that we've identified could occur with this particular algorithm, and the controls that we put in place to make that risk acceptable. And when you're undergoing this risk analysis, you're really looking at, in this scenario, what's the likelihood that harm could occur, and what would be the severity of that harm? And you actually use a calculation to use likelihood and severity and identify what risks are unacceptable. And then the FDA would be looking for you to show that you've mitigated that down to an acceptable level through risk control measures. An example of a risk control measure would be things like I mentioned a moment ago, locking your AI algorithm to say, we know predictably it's going to produce this range of results when we put an input into it. That's why locked algorithms are, there's a lot of approved locked algorithms. We'll speak to it in a moment. Generative AI takes away the ability to do that risk control measure, so you have to find something else. Another risk control measure would be making sure that the data set that you trained your algorithm on is representative of your intended population. Again, generative AI kind of throws that for a loop, so we'll speak to that in a moment. Step 3 would be verifying that you've built what you intended to build. That's why you wrote down your requirements. That's typically software testing. Step 4 would be validating, so running an actual study to make sure that your algorithm, your AI system works in the setting that it was intended to be used in. Step 5 is called transfer. So that's making sure that all the users have everything they need in order to run that algorithm effectively. Installation, training, materials, those types of things. And then step 6, last steps would be the continuous monitoring and measurement of the algorithm in production, which will give you new information about risks and needs that algorithm needs to have in order to be safe and effective, which feeds right back to the beginning. It feeds right back to potentially new intended uses, new requirements as risks are identified. And the whole thing is the quality systems lifecycle. So that's how FDA currently sees it. I did it in 6 steps just to try to keep it really simple. But want to acknowledge that even with the 2 examples I gave, generative AI is a different technology that they will likely use the exact same framework for, right? So those principles at each of those steps, they're going to be looking for how are we still controlling risks given this new technology when we don't have potentially access to the training data. When we do know that it's continuously learning, what other control measures are we going to have to employ? And there's a lot of levers that we can move with that. For example, some examples for generative AI would be, again, limiting the scope of the population that's using that particular tool, right? Are we going to maybe allow that large language model to only be used by the clinical expert that can immediately make a judgment on the spot about whether that output is appropriate or not? Not putting it into time critical or sensitive scenarios and situations, right? Putting it into an emergency room scenario where you have to make a spot decision and you don't leave very much time for that user to be able to process that information or go do their own individual validation. That would be another risk control measure. And the list kind of goes on. We can think about how are we going to, again, take all those line items that we've identified as unacceptable risks and employ risk control measures to reduce those to an acceptable level. That formal process is really what I think about when I listen to amazing innovators like the ones here. And I'm sure we'll get into it a little bit more later.
So I think we have a challenging bridge to cross here. So I think David laid out a very rigorous process that is limited to locked AI systems, an area where a lot of folks misunderstand what is happening with regard to AI systems that have gone through the FDA process. We've encountered time and time again in my prior life where folks said, well, the FDA is handling this and they're using large language models that are employing machine learning. And we're like, wait, they're locked models. So, Adam, as you and Ethan think about your research and the power of that research to transform and drive change, um, we are aware already that there are uh, individuals who are using generative AI systems in rural communities, including rural clinicians, that do not have access to specialty care. For example, our panel just prior to you all was a panel around e-consults, which is a defined way to build more capacity into the system. It involves two clinicians. And there are some impediments to that adoption, namely around coverage and payment, that are limiting the uptake of that particular use of really a well known technological model. So we have this huge demand of lack of access to specialists, growing shortages of clinicians on one hand, a population with that is aging, that has more chronic disease burden, and we have scarcity, something talked about in our keynote address. And on the other side, we have technology, but it's technology like we've never seen before. And in particular, I'm talking about generative AI systems. So we've figured out a way with any number of automated systems. And then the next level were machine learning systems that we could then lock and get those through the FDA and validated. But these generative AI systems feel and look different. And so, my first question for you all is as you look at your body of research and you see the power of these tools, to your mind, where would you want them to be deployed and under what conditions could they be deployed safely? I'll
You want
start
me
with
to take that
Adam.
first, Ethan? Or me, Adam first?
I'll start with Adam.
Oh, yeah, yeah. So if it's a question about what the tech can do, I think there is already some compelling evidence about what it can and what it can't do and where some of those failure points might be. So I'll go ahead. I should have said this at the beginning. My conflict of interest is that I'm also a visiting researcher at Google. So I work on the Articulate Medical Intelligence Explorer, the AMI project, and we actually just published a paper on the ability of this system, which is a multi-agentic system that reads the guidelines, talks to patients, and makes decisions that show that it could make management decisions in chronic illnesses like diabetes and chronic illness management better than people. So a true Turing test one-to-one. So if the question is very narrowly, what could these be used for? They could be used for e-consults, so upskilling generalists to answer questions. They could be used like semi-autonomously, obviously with some degree of human oversight to manage certain conditions. Now, the obvious next question should be, well, what are the failure points? When does it go wrong? What are the limits of these systems, even if experimentally they're very good? And the honest answer is we don't know yet, right? This is very, very early. But with 2025 technology, and this is how crazy this world is. If I just said no more, and I don't know if anybody's been following the news around Claude 4 that was just released, but it's capable of acting autonomously for almost 7 or 8 hours in a row agentically without losing focus. So if you just freeze tech right here in the year 2025 with multi-agentic systems with these powerful reasoning models, we would get to a point with 2025 technology that I actually think it could do e-consults, autonomous chronic illness management. I think the question is, how would you ever know that it was as safe as a human or safer than a human? And how would there be a regulatory pathway to encourage innovators and companies to do that? Because I know that people are not entering this space because of all the regulatory uncertainty.
Yeah, so I think and tell you what Adam said, Sylvia, to your great question, right? About, hey, now that you guys have shown that these sort of tools, right, have a lot of amazing medical capabilities and performance, what applications. So I meet a whole bunch of, I guess, everyone, startup founders, physicians, like, oh, Ethan, where do you think the next big thing is, right? And my honest answer is, I don't know, right? I think that I can see so many promising applications for a lot of these solutions that could be built. I'm not at all concerned about the technology, right? If there's a problem, I'm pretty sure that there would be, actually, I'm very optimistic, right? That there's a technically feasible way to actually produce, maybe not a perfect solution, but something very workable. So I often say, based on your lens, right? Myself, we're clinicians, myself, Adam, right? The benefit is within a health system, David as well, within Mayo, Stanford, Harvard, right? We get to see a very clear lens of all these clinical problems brought to us. So in my instance at Stanford, we are actually, to that point about e-consults, right? We are literally building, something called Sage. It's very much a prototype, but it's a way for a primary care physician, perhaps in a rural setting or within the Stanford primary care system, to get an instantaneous response of what a specialist would say in a given situation. Except instead of taking days, 1 or 2 days to get an email response or taking months, right, in a sort of visiting patient, you can get an instantaneous response of what a doctor would order. Which is all to say that we are super excited about all these applications, but often, the best, most compelling, problems to solve come from where you're based, what you're observing directly on the ground. So that's the first point I want to make. Second, like Adam mentioned as well, everyone is very curious, right? Where are the outer ages, the frontier of this exciting, sort of new frontiers. Um, Within research, a lot of work and attention is being directed towards this benchmark, right? Hence, you might have seen recently, OpenAI's sort of health bench, which is a sort of conversational dialogue, right? How can we at scale validate that these sort of good outputs? Um, I would also encourage people to think about, hey, besides just like how good can it be, right? I think what's really important to think about is how harmful can it get? And between all the excitement, right, which is understandable, everyone's like, oh, how good can these things be? I would love if more people could also think about kind of the downside risks that, I would love to turn the mic to David over, right, in the framework I mentioned, because often it's not about how good is the doctors, right? Hey, when he gets it wrong, how badly, right? How often does that happen? How severe could it be? And I think within my research group, at least, a lot of these sort of attention, right, is being turned to these things because that then allows you to make a much more convincing case, right? When I can be doing, done autonomously, when you need a human in the loop, when you need a human doctor AI collaboration and things like that. Yeah.
So I'm going to pull David in here and make an observation. So I think this is again a situation where there are some assumptions that everyone's making who is deeply steeped in this work that we need to lift out for all of us regular folks. And I think in the generative AI space, one of my questions is, and I'd like to start with David and would love to hear from Ethan or Adam about this, is that these systems are only as good as the prompt engineer. So they're only as good as the person who is asking them the questions, meaning, you can have I'm a lawyer by training. You can have a non-lawyer ask questions about particular judicial proceedings, or you can have a lawyer ask those questions, and the output looks significantly different depending on who the prompt engineer is. And so, David, as you think about these generative AI systems and intended use, I think is a good element to consider here. How would you envision possible frameworks that could work for generative AI from a regulatory perspective?
Yeah. And I think I should have mentioned at the beginning, I'm unaware of any large language models, generative AI tools that have been cleared by the FDA. So this is exploratory and exciting to be honest. And I see confirmation. So following, again, FDA is going to follow their same principles. And I think from a regulatory or quality thinking, what they're going to look for is the validation that those risks are controlled. And in order to do that, you have to be able to compare it to a known truth. And when you have a very open-ended chatbot or AI system, the truths are infinite. and the inputs are infinite, and that's almost impossible to do risk management for. So what I expect, and this is just a brainstorm, is that what the products that are going to get cleared first are going to be the ones that are very narrowly scoped. Maybe just a couple prompts to a known truth. In diabetes management, for instance, help with diet, right? These are the questions we have about the diet, with lots of dietary guides about how to manage your diabetes through diet. Low risk, non-medical device in that case, so it doesn't even implicate FDA, and it would be querying a very known set of standards for how to control your diet for diabetes. Then add on to that. Okay, now what do I do if my A1C is at this level? Well, there's still some known things that you would do that are based on guidance that you could compare to and say, we validated that is actually truthful. But as we grow, the inputs grow, each with their own individual validation. We get more comfortable with these systems, and then we actually end up with a huge suite or library of lots of helpful inputs that start to make it closer and closer to a general chat, if that makes sense. So that's kind of how I expect it to go. It's possible we may take bigger leaps, but there's going to have to be a justification to it. How do we take a big leap to something that's a little more open-ended and still control or validate that those risks are controlled? And again, I think we'd have to pull one of those other levers, right? Go to only very specific specialty uses, go to very narrow uses, or go to low risk uses in order to make those bigger leaps. But I think for the chronic care management, it's probably going to be something that's a lot more incremental when we're talking about the higher risk disease management cases.
So I'm going to kick it over to Ethan and Adam, and I'm going to add just a little commentary. I think the new administration may dramatically reimagine the FDA regulatory process. And clearly, we also have within the Centers for Medicare and Medicaid Services a new administrator who has touted the transformative power of AI systems to take on the chronic disease challenge of the nation in an era of scarcity. So, Ethan and Adam, as you think about the regulatory process, one, is that something that you guys contemplate as part of your work? And then, second, gazing at the tea leaves of the new administration, and if they were going to take a new approach with regulation, um, incremental seems not like something that the current administration is interested in. It sounds like they're really interested in 10x changes or differences in approaches by which we look at AI systems and generative AI in particular.
Yeah, I'm happy to go first. Thanks for the great question, Sylvia. So certainly not a regulatory expert, but I think, within the sort of health system as a provider myself, doing a lot of this health research, have had a lot of conversations, right? Kind of musing, how do we think these things will play out between, provider burnout, shortage, always growing demand. And my guess is that is why I think just guessing, right, that the current administrator, maybe the policymakers are trying to advocate for, hey, more of a 10x change, right? Because if it's going to be incremental, honestly, we're not going to move the needle that much at all, right? Between the aging population and all this excess. So in some sense, I'm thinking it's almost it's not really a nice to have, right? At this point, it's going to be a question of like, hey, we've got a patient, right? I saw the statistic in designing our e-consult system. About 50% of the 100 million referrals of Americans never actually make it to see a doctor, right? So that is the kind of choice, and not like, hey, do I have this versus do I have, a different sort of provider providing the care for me? And I think it's really how to address this gap, which is where, you need really good regulations, good experts like, David, and the sort of research, right, coming together and figuring out, kind of what are the next steps. And then I think unpacking that, there's also kind of two parts to it, right? Which parts can be sort of augmented, meaning AI supporting physicians. And, Adam and myself, our colleagues, right? Every time speaking with them, they are crying out for these tools because so much of practicing medicine is, as I'm sure everyone in this room knows, not so much about the joy of practicing medicine. And I was just musing to a sort of French physician colleague, right? I almost imagine a lot of physicians have that charming notion of, practicing in a small village, having all the relationships, knowing everyone, having follow-up patients. But the reality is today, it's so much administrative work. And I think that is where AI can really take a lot of that sort of workload, burnout, stress, right, admin stuff away. And then I'm guessing that where a lot of this maybe regulators, administrators are thinking, right, is how much of medicine can really be managed autonomously, right? That is definitely more of a moonshot thing. And I think we're just getting to discover, right, even in some of our research, hey, where could doctor plus AI versus doctor alone, what sort of tasks, right, can we delegate away completely to computers? That, when they can manage and crawl through, right, amazing thousands of pages of content in a way that a human, A, cannot possibly do, and two, clearly doesn't enjoy doing, right? Then maybe we think, aha, right, there could be an opportunity there. I'm going to hand it over to Adam to say more because I'm sure he's got really interesting thoughts as well.
Oh, I mean, I don't even know what to add on top of this. I go back to Sylvia's original question, for better or worse. Ethan and I play a part in the government's plans about coming up with possible novel mechanisms to regulate or ensure that these systems are safe. And David is going to think I'm ridiculous because I don't know anything about the legal rules, so I can only talk about how it works in practice. But looking ahead, I think if you're reading the tea leaves, you're looking at one, like robust private scalable benchmarks with human baselines, so you can look at how the systems perform like de novo or in silica, and get a sense on the relative performance and their relative weakness. And then the second is scalable oversight systems, which is something that even the previous FDA, like Hyder Warwick and Bob Califf, wrote a piece that was published in January, and I reviewed, as I'm sure David did, the second piece that was going to come out. And this was going to be and they imagined to be very clear autonomous or semi-autonomous AI, as David was saying, in very specific settings. So like I think AFib and heart failure and diabetes were very specific areas. But they imagined a system where there is a second AI oversight, so an AI oversight system that watches the first system, but that also knows when to report into humans as kind of being the key piece. And as the technologists know, one of the problems with asserting this as a solution to this is those systems don't exist. They don't exist yet. They're probably possible. Ethan knows we have a scalable oversight system that we use in research, and I think that it is a problem that could be solved, but it is not yet solved.
So I have this causes me to have two questions. So immediately, I think Adam, I'm immediately thinking about unmasking AI. I don't know if you all read the book. I'm going to say Dr. Joy Bolwani's last name probably incorrectly, but essentially an MIT researcher who examined the benchmarks used for facial recognition, and it was prompted by the fact that she's an African American woman. And in the course of her study, the systems she was using could not actually recognize her face. She had to use a white mask in order to be seen. So you had mentioned the OpenAI Health Bench, and this notion of these um, private sector developed benchmarks. How do we ensure that we don't have a replication of that same problem in benchmarks that are designed to show both like efficacy and safety and to address a bias, that those systems are representative? Is that part of the the regulatory regime, and how do you address that, especially if the benchmarks are being developed privately? So I'll start with Ethan, and then go to Adam, and then David.
Yeah, maybe I'll give a comment, right? Because that's a very complex, question to answer. Maybe I'll give more of a comment on, the nature of these sort of benchmarks, how they're developed. I think it's very important to look at the who, first of all, and for what purpose, right? So when industry comes up with benchmarks, right, often what this looks like is, hey, they are huge developer teams, right? Not just OpenAI, but other places trying to build, these really impactful, meaningful healthcare application solutions. But because they're an engineering team, right? They, being engineers, technical, they want a quick way, right, to get response. It's not very feasible each time to get huge numbers of doctors, humans, right? Which is to say that they have a very specific goal. Usually it looks like, hey, we want a first general pass at validating, how good the performance is, and possibly over time tracking that improvement in performance as well. To the second point, I would strongly encourage right? Any team, any developer team working on various use cases, think critically, as you mentioned, right? What are the important things that you want to measure? Because it's good to have different sort of benchmarks, right? And you can rapidly apply, prototype, and track performance. But more important than that, as you mentioned out, right? A lot of these things that could have been lost, right? Whether it's diverse representation, whether where the data is coming from, what a use case is going to be, the team developing itself would definitely have the best knowledge on what some of these use cases for and hence how to track that. Which is all to say that all these benchmarks are good. Definitely track as use, leverage as many of them as you can, but also think carefully, right, about what are the sort of internal things you need to check that your product is working representative, diverse enough of data for your particular use case. So that's my point of view, and I don't know if Adam or David wants to add on anything else.
I'll add on one thing really quick about trust. So I think a problem with benchmarking arguments, and we saw this in the last administration when there was this talk of assurance labs, is like, okay, I think there's wide agreement. You can't health bench like OpenAI's health bench is never going. It's not at all. It's not meant to or sufficient to benchmark actual clinical care. Um, but you can't have a public benchmark. We've seen this again and again with AI companies. If you have a public benchmark, they're going to make the models, they're going to modify the models, fine tune the models so they do really well on the benchmark to pass the test. So it has to be a private benchmark, which means, to Sylvia's point, you won't a priori know how much diverse data is in there, where the failure modes are, whether it's being fair to all populations, which means that if there is to be a benchmarking strategy to do this, there has to be trust. It has to be done by an institution in which patients, doctors, health systems have trust. And I think once you define those problems, and this was, I don't want to get too political, but this was always the problem with the assurance lab model. Like as a researcher, I'll tell you, I didn't trust them. Like I had no reason to. So who is that trusted group or organization or nonprofit that is going to do that? And this is really like, this is what's so weird about language models. Like all we have is trust because there is, as David says, they are general purpose systems. We can't test them. And you could say, Adam, you can do a randomized controlled trial. Well, an RCT is a product and only a single, and I'm running a clinical trial right now. So when anybody says, oh, just do RCTs, I want to strangle them because it's really hard to do RCTs and takes a long time and very expensive. And who's going to pay for that? Which we will for specific cases, but even an RCT doesn't get all of those failure modes. So if this is going to work, it has to be done by somebody who is trusted above all else.
Yeah, I completely agree with that. And the benchmarking is really hard. There are already existing infrastructure and systems in place for benchmarking within medicine, right? Consensus, peer review, which is great. So I think leveraging those is really helpful. But even within that, we have found in some of our algorithms that we built differing opinions across different pockets of the country, even with respect to like certain diagnoses, right? What's the threshold of a diagnosis of this disease? They may think about it one way here and differently over here. And if there's not that consensus, it's really hard to have a benchmark. So the other things I think about, just to add on to your question there, Sylvia, is accountability and transparency in addition. So accountability being, we still need to do a better job overhauling the system to make sure that those who are in the best position to take accountability or liability for certain aspects of delivering generative AI into healthcare, we need to make sure it's clear so we don't just get the finger pointing thing. People should know what they're accountable for so that they can actually contribute their expertise into that equation. And it likely will be shared accountability, but it should be clear. And then with transparency, I think what we'd be doing with the benchmarking is putting it in the hands of the user, right? So citation, direct links to the source or the reasoning behind why a certain output was provided. Give that to the user, and especially if the user is an expert. We've done a little bit of benchmarking by making sure the expert can tie it to their knowledge that they've been trained to provide for that particular workflow or setting.
So, we are going to have the three of you back for a part two because I have, I think, two big questions, and we're not going to have time to get to. So, a rapid fire sort of end really quickly. I'd like to ask you all your thoughts on the impact of flagship institutions having the capacity to design, develop, deploy, and validate and evaluate these systems as compared to sort of the safety net and rural providers. It seems like these activities, which are important for advancing medicine, it's also very starkly demonstrating sort of a pull away where these other community health centers, critical access hospitals, many of the folks that we work with, they are not part of the enterprise. And so, is there a solution? And it could be yes, no, maybe, and who's going to be the driver of it? Is it going to be policymakers, the profession? So rapid fire, David.
Yes, we absolutely need to democratize the knowledge. We've already experienced it, like with electronic health records, but there needs to be funding in place to be able to support the under-resourced organizations to be able to pull in and leverage the information that's coming from the larger institutions, partnerships, and other entities that can help deliver that information.
Ethan.
Sorry, I couldn't follow the full question. Could you repeat the question, please?
There's already a disparity growing between the flagships and low resource providers. How do we overcome that?
I think this is always a tricky one, right? Because the reality is that the AMCs are always going to have quite a bit more kind of research resources. I think that a group such as, what you're leading, Sylvia, bringing together the stakeholders to kind of exchange best practices, forums, conferences, that is probably a best way to sort of pass on and share information and exchange knowledge on what could work well. Speaking more towards what types of AI solutions, who are good vendors to work with, what are implications of findings. So in my head, that would be one of the more feasible way. I imagine that some of these kind of disparities could be addressed. But I think to be fair, I think this is a hard thing to solve, and it's always an ongoing thing that, myself, Adam, sometimes talk about as well.
And Adam.
The answer is yes. And the WHO, I don't think academic medical centers are going to solve this for critical access hospitals. The answer is the government. So I don't want to, again, I'm visiting researcher for Google, so like take the corporate thing but like these are solvable problems and they could drastically improve healthcare, but nothing will be solved if we don't have government regulators come up with a safe way to regulate and deploy this technology. And if the rules are set, the tech exists and the tech does what it's going to do and people will build it. And then you can just get a cloud provider and get a play there. You don't need to like jury rig and hack stuff like what Ethan and I do at Harvard and Beth Israel. So I think, and this is a people problem. We need really smart people in the government to work with people, in industry and academia and come together. And I do not think this idea of company self-regulation is going to work. I hope that is not the plan. I think that will actually kill innovation because of the liability concerns. But if the government can come up with a regulatory regime that works with these potentially very powerful technologies and set rules, I am very optimistic that we'll be able to make health better for everybody.
Fantastic. This was an amazing panel. I'd like to thank all three of you, and I'm going to hand it over to my colleague here, and we hope to have you back for part 2.
Hey everybody, I'm just going to do a few quick housekeeping items to wrap up briefly. We can go ahead and go to the next slide. For ongoing support, make sure to check out our CTRC website at caltrc.org, where you can find events, webinars, on-demand resources, and more. You can reach out to us directly at caltrc@ochin.org. We have some upcoming events on the next slide. CTRC is co-hosting our first Healthcare AI Bootcamp with virtual and hybrid sessions from June through August. Registration is going to open on June 1st, which you can access through the link on the slide, and we will share it in the chat as well. In the next slide, you can sign up for our newsletter to stay in the know and subscribe to receive latest updates on trainings, webinars, and on-demand resources. And then lastly, the next slide, I want to take a minute to let everyone look at our survey. Want to request that everyone take a minute to fill this out in our remaining roughly 60 seconds that we have left. We want to ensure that we are meeting your needs. If you have any feedback or ideas, that's very helpful for us to know. Please let us know via the survey. And we are already getting some popping in, so thank you so much for filling that out. And as you all are taking a minute to fill out that brief survey, I'm just going to say another thank you to our wonderful speakers and to our attendees. And just a reminder that I believe we have our lunch break coming up, and then we will be back with 3 more great sessions this afternoon. So thank you all.